Okay, we'll go ahead and get started with grand rounds this morning. We introduce Dr. Stewart to this podium a couple of times a year, so I'll try to just hit the highlights. Dr. Stewart is a native of Odessa, went to medical school here where he was named into AOA, was a resident here, and then still to date is the only resident ever to win the Southwest Surgical Congress's Resident Research Award twice for his work on basic science work on snake bites and his clinical work on small bowel obstruction. Went to Memphis for his Trauma Critical Care Fellowship and then rejoined the faculty here in 1993. And since that time, most of you know he's worked through the ranks to become our chairman. And along the way has achieved many honors, the most recent of which are being named to the American College of Surgeons Board of Governors and being named president-elect of the Southwestern Surgical Congress. And today he's going to talk to us about trauma systems, an area where he's very knowledgeable as he essentially built the current trauma system in South Texas where we practice. So, Dr. Stewart, welcome.
Thank you, Dr. Dent. It was very kind. Of course, the working in the trauma system is not me. It's really everyone. It's people in this room, people who came before me, and the people on this slide with respect to the trauma system itself. I'm going to try to tie together things that are not necessarily tied together everywhere. They're very, very, very linked here in South Texas, but so it's a beautiful time in South Texas. This is the time for wildflowers blooming, and it really is an amazing time, the mid-March through mid-April. Not everyone thinks April is such a good month, though. This is a small paper in California, editorial author there. This is really picked up by NBC and ABC, and although statistically not true, it does seem that April, this is a good time to be talking about disasters in a way. And I'm not just talking about the events of this past month, I'm talking about historically. So there's lots of data that trauma systems save lives, decrease mortality, improve outcomes. But if you think about the trauma system in a way, it really deals with routine, multiple, small-scale disasters on a daily basis. And to deal with that effectively requires structured cooperation and communication. And the trauma system response is not really conceptually different than disaster response, or for that matter, other time-sensitive medical problems. This is where we are. We're in Trauma Service Area P. This is a test to see if I know where we are. So this is Barrett County. We're in Trauma Service Area P. Trauma Service Area P encompasses 26,000 square miles. And we also serve T, U, and V, the lower part of the state, which has another 26,000 square miles and about another 2 million people. This is a large geographic area with a lot of heterogeneity with respect to population density, and we have lots of things that can create disasters. So the most common disaster we deal with on a daily basis, fortunately for us, rarely impacts us directly, but hurricanes hitting the Texas coast. This is Katrina. Now, to be fair, these hurricanes hitting the coast do cause most of the damage there, but they do spawn a lot of rain and occasionally a tornado. Probably the most common disaster that we see that directly impacts San Antonio is flooding. San Antonio and its surrounding areas has always been very flood prone, and this is the confluence in I think this is 1998, the confluence of of the San Antonio River. This is what it looks like from the air. This is what it looks like when you're on the ground trying to rescue people. It's quite a difference. And in a way, this talk is a bit like that. We're talking about it from the air, but when you're in the middle of a disaster, it doesn't seem, this seems, oh, it's kind of wet, but it looks like a lake. This seems like it might be a serious problem for you. So I'm going to talk about the approach to disasters, and one of the approaches, of course, the most effective is to prevent disasters from happening. This is the 1921 flood in San Antonio, and historically San Antonio had multiple floods over long periods of time. And San Antonio has one of the most sophisticated flood control mechanisms in the world. There's actually a couple of tunnels that start on one side of downtown and end on the other, so that the tunnel goes completely underneath downtown San Antonio, so that this is the tunnel during its construction. But you can see there's two separate flood-controlled tunnels that divert water during peak flooding times underneath downtown to avoid this. It is recognized that, of course, that this is an economic disaster. So San Antonio has a very sophisticated flood control system. Probably our not most common, but potentially really serious disaster would be tornadoes. This is one of the most photographed tornadoes in the history of humankind. In 1995, striking Dimmitt, showing the formation of the funnel cloud as it forms what was a F3 tornado outside Dimmitt. This is the Gerald tornado, 1997, which essentially wiped out Gerald. It essentially wiped Gerald completely out. And you can see the formation of the funnel cloud. This is a multi-vortex tornado. The Native Americans had a description for this, walking dead man. And indeed, this tornado created a swath of destruction. The force of it, just to give some idea, removed a 500-yard stretch of asphalt on a road a foot deep. So it removed the asphalt from the road surface. The deadliest tornadoes in Texas, we think of it, well, I'll say I think of tornadoes in the Tornado Alley as the Panhandle of Texas, Northeast Texas, so Wichita Falls, the Panhandle, Oklahoma, which is true based on probability. But these are the 10 deadliest tornadoes in history. The tornado in Waco in 1953, many people believe changed the fate of Waco. Waco was a thriving industrial place, and that tornado the day after Mother's Day essentially changed Waco for probably more than a century. So that I think of the Tornado Alley, but if you look, 3 of the 10 most deadliest tornadoes, Goliad, Rock Springs, and Carnes DeWitt, are in Trauma Service Area P. And an F4 tornado actually hit. So some people think, for those of you who live on the edge of the hill country, they think the hill country is protective and the Balcones escarpment that's not true. But an F4 tornado hit Helotes in 1953, so it's not out of the realm of possibility. This is, of course, the scene from the bombing at the Boston Marathon. This is San Antonio in 1979. This is a lone shooter in a trailer. It's at Flambeau Parade, basically killed 2 people, injured 17, multiple casualties. 5 police officers were shot. And so clearly San Antonio is not immune from these problems. And this is, of course, the fertilizer explosion in West, and the destruction from that from that event. This is a NTSB report from a railroad incident in 2004 outside McDonough. Anybody know where McDonough is? So it's right outside. If you go on Loop 1604 in South or driving around South San Antonio, drive through it. But a Union Pacific Railroad train derailed, releasing chlorine gas, killed 3 people, injured 23 civilians at the scene, and 6 emergency responders. McDonough is not very populated. If that would have happened in a different train station, we would have had a serious disaster in San Antonio. So disasters, by definition, are large scale. They have far-reaching consequences, and they tax and stress local, regional, or even national resources. One of the problems with disasters is they're very low probability events. So they're low probability, high impact events. Surgeons are experts at dealing with high probability, relatively low impact. Now, we don't think of it as low impact because people's lives are at risk, but in reality, disasters are different in that it's a low probability of happening, but creates large effects. And this is a problem for humans, particularly for surgeons, because we're used to thinking high probability. We think when you hear hoofbeats, think horses, not zebras. But I think it's actually hard for us. If you think about complications, for example, it's hard for us to really. We can't tell the difference between a 0.5% incidence in surgical site infections and a 2% in surgical site infections, just because we have a hard time dealing with those numbers. So it's hard for us to prepare and stay prepared for low probability, high impact events. But there are common patterns that help with respect to this. So the 9/11 Commission issued a very large document, and they cited 4 things that led to a failure to adequately prepare for 9/11. First was the failure to conceive that it could happen, the failure of imagination which sort of gets to the point I was just talking about. It's hard to imagine that it could happen, and it's certainly hard to prepare for it. So 2 was a failure of policy. This is really the failure to have a right infrastructure in place. So you need infrastructure. 3 was a failure of capability. That's really a failure to have the right resources. So you have to have the infrastructure, then you have to have the materials to respond. And 4th was a failure of management, the failure to coordinate the available resources and infrastructure to prevent or stop the event. And there are common problems. Not only are there common patterns, but there are common problems with respect to recent disasters. Communications failures are a common theme. Failure to integrate existing infrastructure, particularly the trauma system, and really unworkable and untested plans. This is Eric Epley in New Orleans in Katrina. This is Walmart. So if you walk through Katrina, it had all of those failures that I just talked about. It had a massive failure of communications, a failure they didn't really have an existing trauma or emergency healthcare system, had all of those problems. So how do trauma systems, we talk about trauma systems as if there's some magical things that's really good and saves lives. Well, it's a little crazy if you think about it. But so how do trauma systems save lives? Well, they save it. The trauma system saves lives by a few simple things, not magic. Coordinating care, making certain that people know when there's someone hurt that you can get treated. Ensuring availability of resources, making certain that those resources are available. Setting, verifying standards, and working on performance improvement. If you do those things, if you improve your coordination, if you make certain you have available resources, if you set and verify your standards and work on daily performance improvement, things get better. So what about trauma system with disaster response? Well, they're very much related. For a trauma transfer and disaster, for the trauma patient, prevention is key. It's the most effective. It's the best bang for the buck. Preventing the injury from occurring is the most effective, and preventing the disaster is the most effective. Of course, you can't prevent all these things. So when you're injured or when injuries occur, you have to have an acute care system that basically is made up of the paramedics, nurses, physicians, the hospitals, and the communication systems to care for people, same as in a disaster. The trauma patient moves on to rehab, whereas an area moves on to recovery. The only difference is the trauma system deals with low complexity events, and a disaster by definition is a high complexity event. But really, when you boil it down to, when you really sit and think about it for long periods of time, like 20 years, both systems require structured cooperation and communication. That's really what it is about. It's about structuring cooperation and communication so that you're essentially hardwiring it so that we all know that it's good to cooperate and communicate, but hardwiring it makes the difference. So what about problems with trauma patients and disaster response? Delays are a problem. And without active management, delays occur. Let's talk about the simple, straightforward trauma patient. There's the time for the doctor, when the patient arrives, there's the time for the doctor to decide to transfer. Then if I'm the transferring doctor, I make the decision to transfer, I have to be able to communicate with someone and find someone to transfer the patient to. So there's some time involved with respect to that. Then it takes some time for Dr. Stewart on the other line to decide to accept the patient. Then it takes time to transport the patient. If you think about this, each one of these is a potential problem. So potential problem, and delay is common without active management. Well, what about disaster response? Think about disaster response. There's the time to decide what to do. We've seen, if you go back in the past decade, we've seen problems when highly criticized, slow to respond, time to decide. Then there's the communications, communicating to people, getting information, time to identify your resources, and quite frankly, without active management, delay is common. So we basically had some simple hypotheses. It's not rocket science, in that a functioning regional trauma system basically improves outcomes with respect to disaster response. And not only that, it provides a framework or a skeleton infrastructure for other time-sensitive medical conditions if you have providers. So, for example, cardiac and stroke care. There are some alternatives to the trauma system that are worthwhile talking about. The public health system has really made the biggest difference probably in our lives, in the health of Americans, that the public health system is a viable alternative, which I will walk through, in the emergency management system, which is the existing federal state infrastructure for disaster response. And the trauma system is not a substitute for that. It merely is an integration piece to that. So what about the public health system? As I said, it's largely responsible for health improvements in the modern world. And public health has a focus on the safety and well-being of populations. And it focuses on the services that benefit the largest number of patients. It's multidisciplinary, and it's eradicated disease and improved health all across the world. It has a logically coherent model, which is define the problem, identify risk and protective factors, develop and test intervention strategies, and ensure adoption. This is actually the Model Trauma Systems plan that HRSA distributes, is basically built on this model. This is a great model. But it is worthwhile comparing public health versus trauma with respect to culture. So in public health, decisions are made with deliberation. Diagnostic processes typically take hours to days, sometimes weeks. And it's important to have a centralized bureaucratic system with rules and lots of documentation. Why did that system evolve that way? Because public health decisions, when you make a public health decision, it has widespread political and economic impact. It affects millions, potentially billions of people. So you need such a system. And with public health interventions, there's always the high risk of political fallout. What might seem to the public health practitioner to be the simplest, most common sense thing is sometimes met with horrible resistance and outcry from the public and politicians. So the public health system has decisions have widespread impact, and there's oftentimes high political fallout. So what about surgery? Well, decisions are made rapidly. Typically, with respect to the events we're talking about, clinical decision making is emphasized. If you take the Rural Trauma Team Development course, which is a great course, by the way, even if you're not a rural practitioner, it emphasizes making the decision to what to do with the patient without any labs, without any x-rays, within 15 minutes. It's not a centralized system. It's actually a distributed, complex network with real-life communications distributed over large areas. And decisions have typically a single life impact. So it's obviously critically important to us, critically important to our patients, but it does not have usually the same widespread political impact of public health. And there's an emphasis on personal accountability, and quite frankly, there's usually a low risk of political fallout with respect to the things that we do. So there are differences. So how to integrate disaster preparedness into the trauma system? Well, communications. Communications are far more important during times of disaster, and they're far more likely to fail during a disaster. So not only are the communication is more important, more vital, but it's prone to failure. We know that from past experiences. If you look, it's the weak link typically of disasters. And it's I believe is a common denominator of major failures of disaster response. So why is it so important? Well, we talk about getting the right patient to the right hospital in the right amount of time. Just as the right information to the right people in the right amount of time equals an effective response. If you don't get the right information, or you get the information to the wrong people, or you get it to the right people, the right information to the right people, but it takes too long, all of those lead to a significantly worse disaster. So we have a routine daily communication system that I think all the residents and most people know as MedCom. MedCom is a communication center it was specifically designed to reduce trauma transfer delay. In 1996, prior to 1996, we literally had train wrecks stranded throughout South Texas that basically people could not get in. The message went sort of like this: ring, 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 call University Hospital. We have no ICU beds, thank you. Ring, 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 call BAMC. Are you a military dependent? No. Okay, sorry, we can't take you. Ring, 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 call Wilford Hall. Oh, are you a military dependent? No, we can't take you. Ring, 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 call Methodist Hospital. We're happy to take you, but you need to find a surgeon. Ring, 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 call Ronnie Stewart at University Hospital, now 4 hours later. That's the way that call went. And we had people who I can tell you who I think died from being stranded in such a system. And so this was created to specifically prevent transfer delay. It's a single toll-free number that you call, and you get all of the level 1 trauma centers, and it's seamlessly behind the scenes routed to one of them. We're actually right now in process of involving the level 3 trauma centers, so North Central Baptist and Methodist Hospital. Single number, you call one number, you get and you're rotated automatically to the physician and hospital. And there was an agreement reached between those 3 level 1 trauma centers, Wilford Hall, BAMC, and University Hospital, that we agreed to a common definition of capacity. That was, if we're open to San Antonio EMS, we're open to everyone else. And we administratively pre-approved those trauma transfers, and we designated that rotation schedule, and we made it available 24/7. It actually is quite a simple thing. It wasn't simple at the time, but it's very simple, very straightforward system. And if you look, the implementation of MedCom reduced trauma transfer time. You can see, and we didn't actually have data going back to 1995. My hypothesis, it was up here. But if you look, there's a decision, the time to transfer the patient, to decide to transfer the patient is still a problem. But basically, MedCom has reduced trauma transfer times. So the thing is, in the middle of a disaster, though, in a wide-scale event, those 2 communications technicians sitting over at the AirLife console cannot handle the communications that are required during a wide-scale disaster. So this led to the development of the Regional Medical Operations Center, which I think of as since most of you are biologists, I think of it as an upregulated MedCom. It is a MedCom it is a MedCom on steroids. It's essentially the same people, but during a disaster, during a disaster, it was realized that in our plans pre-9/11, we basically had pretty much one doctor at the Emergency Operations Center, one physician who in the plans was if a hospital went down for some reason, let's say a tornado hit a hospital, that person, or maybe there was a couple of people, they were going to pick up the phone and start calling people. That was the way that was supposed to work. Whereas the police and fire people would laugh at you if that's the way you did it. The police chief, when they want to dispatch 20 police officers, they don't pick up the phone and call individually each one of those police officers and ask them to come to respond to the scene. No, they have a whole system that gets a lot of people mobilized at the same time. So some really smart people in our regional advisory council, Eric Epley among them, came up with the idea we need a regional medical operations center where we have every health system and every EMS entity sitting in a room talking to each other with secure communications links back to their facilities. And that's really what MedCom is. These are all the people. This is the old room, but basically people sitting around a computer terminal with phones, with satellite radio in the Emergency Operations Center, and they're connected to both with phone and data link to their hospital, and they can see everyone else's hospital with respect to their bed capacity as well. So, with the Regional Medical Operations Center came an expansion of hospital involvement over what most people think of as the trauma system. When many people think of trauma systems, they think of, and actually I think of it really, MIMS, for example. You think of the Maryland Institute for Emergency Medical Services, which is centered around a single trauma center. It's centered around shock trauma. Well, that probably actually works quite well most of the time, but it doesn't really work very well in wide-scale events. When you have, if you're planning on taking all the patients to one hospital and that hospital no longer exists, you have a kind of a big hole in your plan. So expansion of other hospital involvement and other EMS was followed MedCom. So MedCom, as I just laid out, there's basically people sitting around the room that represent all the healthcare entities in the room. Those are tied to the Emergency Operations Center and ultimately up to the state Emergency Operations Center. This led to an expansion of work, committees, work groups, and ultimately integration with local regional disaster response. So that was where we're looking at MedCom previously. This is actually the new county city emergency operations center, in a secure location. So the RMOC is really the health component of the Emergency Operations Center. And there's, we won't go into details. I don't think it's really relevant for everyone to know, but the software has been developed and adapted to use in this system so that you can see all of the hospital beds in a region. Robust communication, so not only software tools, but redundancy, land, cell, satellite, internet, wide local area networks, and old-fashioned radio are used to enhance communication. This doesn't mean that this will prevent a communications failure. It just reduces the probability of a communications failure. And in the event that when other communications go down, or if people are being deployed to that large area, there are systems to, on the fly, completely replace communication systems through mobile routes. So in day-to-day mode, we basically have the MedCom working. In crisis mode, you basically go to the political infrastructure makes a decision to go into crisis mode, then you go to RMOC in the Web EOC. So what are the benefits of this Regional Medical Operations Center? Well, if you think about it, for those of you who have thought about it a lot, we really don't have, in a modern healthcare system, there is really minimal what people call surge capacity. There's minimal surge capacity. Back whenever I was a resident, there was quite a bit of surge capacity. You had, when you did a cholecystectomy, you stayed in the hospital 4 or 5 or 6 days, and you had lots of inpatient bed capacity, and it was not viewed as necessary to eliminate every unnecessary bed that you had in the hospital. In a modern healthcare system, with the shift to outpatient, there's been really emphasis on efficiency, so you have very efficient hospital operations that have very little excess capacity. So the benefit of the RMOC is that you have a virtual expansion of bed capacity. What do I mean to that? Instead of now sending patients to 2 or 3 hospitals, if you can send them to 40 hospitals across a region, or you can even link to other regions and distribute those patients even further, it really makes a difference with respect to capacity. You have the ability to deploy ambulances in groups, so you can coordinate 300 ambulances or 500 ambulances across the entire state. So these things have made a difference. This is a group of ambulance strike teams that are basically about to be deployed. This is the mobile medical unit set up in a staging area as part of a drill. So some RMOC results, and to be fair with respect to the Regional Medical Operations Center, it's really pretty much been tested in events where there's a disaster somewhere else. There's a disaster in Houston, there's a disaster in Corpus, but it's been highly effective with respect to coordinating transfers during Katrina, during Rita, and Hurricane Ike. There were 2,100 patients that involving approximately 30 coastal hospitals that were transferred to 17 different hospitals and then repatriated in the next week pretty seamlessly, transported by 525 ambulances coordinated from San Antonio. So the advantages of this process are better communications between agencies and stakeholders, better and faster communication between those same people, better distribution of patients, better distribution of resources, a better understanding of what your local needs are at the time the event is happening, and better patient tracking. So in conclusion, the RMOC improves cooperation and communication. The MedCom reduces trauma transfer times and integrates the trauma system into the emergency response system. In real ways, we think of that system as the trauma system is essentially the infrastructure for disaster response. So where do we have weaknesses and opportunities for improvement? I think we have opportunities for improvement with respect to surgical mass casualty preparation and planning. What do I mean by that? I've just talked about a really elaborate system that can coordinate, that with a couple of hours or even minutes notice can get up to some rudimentary speed and make a lot of these decisions. We're not talking long periods of time. But I think in our hospital, the hospitals we work in, I think we still have challenges with respect to mass casualty preparation and planning, i.e. getting people there, how to do that triage. It's not something that civilian hospitals are really used to doing. I think we also have a weak spot with communications to physicians and other providers. There's been, in the past 10 years, pretty much the 10th year anniversary for iTunes was yesterday. It pretty much coordinates with that. Most communications between physicians and other providers are now by smartphones. So I personally use it. We use it all the time. But during a disaster, it's well known that those systems will fail early, and it will be a communications problem. So if our plan is to call each other on our iPhones, it's probably not a very good plan. I'm not going to go into the data, but we have data with respect to other time-sensitive medical conditions, ST elevation, myocardial infarctions, and stroke in particular, at least showing significant improvements in access and probably outcomes with respect to those things. So in summary, integration of the trauma system with the disaster system basically leads to improved preparedness and response. And this is, to me, a natural evolution of the regional trauma system, and also leads to potentially other benefits for medical patients who 10 or 15 years ago we would not have been thinking about at all in the trauma system. So with that, I'm happy to answer any questions.
Dr. Stewart, have any other parts of the country adopted what San Antonio did? They were the forefront, weren't they, as far as setting up this regional communication system?
Well,
do we have it across the United States, or are we still?
No, we don't have it across the United States, although we have it across large chunks of Texas now. I do think that the people in San Antonio and South Texas, the people of that team of the Southwest Texas Regional Advisory Council, as a group of people, have been particularly innovative with respect to these systems, and particularly about applying information technology and communications technology to these, i.e. improving structured cooperation and communication. And it is not really widespread outside of San Antonio. I presented this, basically a variant of this talk at the Las Vegas trauma meeting a few weeks ago, and it's definitely not. It's not everywhere in the U.S. And it's not totally hard. We've tried to sort of sell this idea, but if you think about it, the data that you only get during disasters. And so we've had a shortage of hurricanes in the past 5 years. And so there's just not a lot of data with respect to the way it works and the way we're used to dealing with implementing things across the country is you get data that shows that it works and then people do it. So we have some data. The short answer is it's not adopted across the country. But
there was a lot of interest after 9/11. Even the college got all fired up, looking into this. But then, with time, it kind of dwindled.
What's the model that was used in Boston? I mean, that's the most recent. Do they have a similar?
The short answer is I don't know. I mean, I thought Denver did a good job of just on the surface. So nobody really knows these things. If you don't get a debrief for how the system works.
Well, that would be a good idea, right?
Oh, yeah.
So
That's
that-
actually an advantage of the RMOC system, if you think about it. If you actually could know where all your patients went and track them, and then you could put it back, it's absolutely critical.
It seems like what you need is something similar to the FAA when there's an airplane crash. They swoop in to find out what were the factors and what actually caused it. And, you know, we know some things. You know, the MGM Grand fire in Las Vegas in 1980 or 81, they had so many casualties, they only had one triage center initially. And so one of the lessons they learned is that when they have that many, they need to set up more than one triage area. When you think about Houston flooding, the hospitals had their backup generators in the basement. And that's why all those hospitals were out of business. You know, and you wonder whether somebody has done things to make, you know, to help with these corrective measures.
Well, they have. And Houston's been a big adopter of they don't call it the RMOC, they call it their own name, but this has been definitely spread across Texas. But I mean, just for those, it's not a surprise to probably people in the audience, but I mean, if you sit in on those conference calls during the coastal hurricanes, it's quite amazing the things you hear on the conference call. I need a generator now. Really? Need a generator now?
We got one on the pickup.
Can't you send it by helicopter? I mean, literally, you hear those. So that gets to the point of the 9/11 Commission on the failure to imagine and prepare for something that seems remote and doesn't seem obvious to next quarter's bottom line. It's hard to prepare in the modern world for that.
Dr. Dent?
I think you've outlined some of the challenges in how we overcome them with larger resurgence and EMS. What I've had a hard time envisioning is like the biological warfare that ends up being or ends up being an infectious disease issue, and getting medicine doctors and ID doctors and so forth to think, hey, this is a mass casualty ID situation, we need to mobilize our troops and get involved in this process. And I guess I know we've been pretty fortunate with Jan Patterson here kind of spearheading that, but on a broader scale, I don't know that that's going to work well in a lot of places. What are your thoughts on that?
Yeah, well, I do think it's certainly it's one of the problems when you're trying to prepare for this whole host of things that are relatively remote. How do you get people engaged in that process? I'll just say that the STRAC San Antonio approach to that has been to basically have a collection of work groups of content experts who basically are meeting on a routine basis. So you talked about ID. Well, there's other things: pharmacy supplies, morgue, how to deal with it. So there's a collection of work groups of people who meet and who talk about those things from a more practical point of view.
It's important when you mention that, because when the Board of Governors of the college looked into this, especially after 9/11, there was a train bombing. Was that in Italy? In Spain. Right after that, they investigated that. And actually, there was no need for general surgeons. What they needed were ear and eye guys and orthopedic surgeons for the extremity loss. I'm not saying that we're not needed in it, but you have to consider about how these other specialists need to be brought in. Dr. Adelot.
Yeah, I would say that whoever came to the conclusion that you don't need general surgeons in a situation like Spain probably was a bunch of ENT ortho guys.
Well, no, this had to do with the Spain train thing.
Yeah,
It was all extremities and head and neck.
So Dr. Adelot you typically make a point that you need general surgeons, but you also need everybody else, correct?
you do need everybody else. This also speaks a little to Dan's point. Dan continually argues with me about this. No. You can't put a system in place in your hospital with a bunch of surgeons, knuckle-dragging surgeons, and then all of a sudden, oh my gosh, it's anthrax. Yeah, you can. Because what happens is we know how to do everything pretty well. I mean, I know no one wants to do it. And it sounds really kind of cocky, but it's true. So if you put together a whole bunch of surgeons in your place and we're going to take care of everything, we think what's coming in is a bunch of penetrating injuries to this, a bunch of legs falling off, which is true. And then we realize, oh my gosh, they're coughing up blood and they look really sick and no one really has holes in them. Well, I mean, it's not going to take Dr. Myers like 10 minutes to think about it for a while. He's going to say, well, maybe we should just shoot like shoot a chest x-ray. Look at that. And next thing you know, we know how to involve our people to make it happen.
I think that's knowledge of the system.
Systems-based practice.
It's one of the core competencies. You get special points for that.
Dr. Savu.
Thanks for that talk. Something you touched on is the communications, and I have a surgeon friend from Israel, and the first thing he says, they get a bombing because they deal with this all the time, and the first thing you do is you call your family on your cell phone because they're going to shut down the whole citywide cell phones within 5 minutes of that bombing. So you touched on that, how we're not going to be able to communicate. Are there key players in the city that have other means of communication at their disposal immediately? It's like just walkie-talkies and things
Oh,
like
yeah.
that? And if there were, and I also, did training in New York, so I knew a fair number of the surgeons when 9/11 happened, and they said they could see what was happening, so they canceled their elective cases and waited. As it turned out, they didn't need because the patients were either dead or then they had burn units. But they were very efficient. They, took patients on the ferries across to New Jersey because they knew the traffic, things they weren't going to be able to move around Manhattan, and they actually did very well during the tragedy. Unfortunately, there are a lot of surgeons just standing there waiting. But I thought, well, as I'm not so involved with trauma at the moment, but if there were a mass casualty and needed people like myself or other people to help, how would we know who to talk to? Because I agree, I don't think the phones are going to be working. We may be like Israel someday and shut down our phone systems, especially like with Boston. They were thinking it might be phone detonated and things like that.
Yeah. So, short answer is, I think we're in better shape 5 years ago than we are now with respect to communicating with providers, and that most people had several different ways to get in touch with them. And the key players do all have redundant communication system, including satellite radio. There's people on this list of people, you can get them wherever they are in the world. I guarantee you can find Eric Epley, no matter where he is, you can get in touch with him. That same thing is not true of our surgeons and medical providers right now. I don't think it is. I personally think, that's one of the helpful things for me for doing a talk like this is think, well, how are we going to communicate with each other? Because right now it works great. It actually does seriously work great. It's quite easy to communicate with people. You send a text message and you get 20 people, but I think we've got a problem right now with respect to communications for medical providers. And we have your home phone numbers for the trauma people. We have a way to get in touch with them through MedCom that they're experts at finding people. But with respect to a wide-scale disaster that involved multiple other people with a failure of the cell network, I think we have a communications problem with the providers. Communications actually among hospitals will be great. I mean, great, let's say it should not say it that way. Say, has a high probability of being intact, but not entirely clear to me that hospital communication with its physicians and nurses, not certain about that right now.
Dr. Eastridge.
So, Ronnie, if you talk into Norm McSwain and some of the other people that have been involved in these big disasters, they noted that they thought their primary issue was failure of leadership. So how do we deal with that in an era when those support programs at local, regional, and federal level are being cut or wiped off the slate, to balance the budget?
Well, so far they're not cut. So the hospital preparedness program is preserved so far. We've made a big push to preserve that I think that's a really important program. particularly when you think of a disaster. I mean, everyone here's a healthcare provider. But if you think about the bad things that happen after a disaster, most of them involve health. It's really about, if it doesn't involve health, then it's probably, you're going to be able to manage it, be fine. So it involves health. So the hospital preparedness program is really important. I'll say with respect to leadership, where I'm not certain I agree with all of that, in that it's what we all should know. The people in this room are going to be the people who respond for a disaster. What we should know is the best place to find a helping hand is at the end of your own arm for the first 48 hours, for sure. For the first 48 hours, you are on your own. We're on our own. So the quicker we realize you're on your own and nobody's coming to help you, no one can come to help you in that amount of time, you're essentially on your own. So with respect to leadership, I think it's really important that we have strong local leadership, distributed leadership, and people who can fill in those instances. And I think that's particularly key. I guess that's really one of the key points about this talk, is that the people who deal with these multiple small-scale disasters on a routine basis, those are going to be the people who need to be in a leadership position when it becomes a wide-scale event, at least until other resources come to bear that are larger than what you can provide. Dr. Bauer.
Yeah, part of Houston was.
Can you say a word about the response up to West, because that Stratton and other people were involved?
Oh yeah, so I didn't talk about. So we had people. It's one of the beauties of this system. We had people within 5 minutes, 10 minutes on the road to West, and of course it's a little bit like whoever, I can't remember, someone talked about 9/11. In reality, once they got there, most people were either dead or they were sort of walking wounded. But we deployed ambulance strike team immediately, 2 ambuses from a coordinated response of ambulances from San Antonio, Houston, and Dallas. We deployed this Type 2 mobile medical unit, which involves a structure, emergency medicine physicians, emergency nurses who are actively practicing in hospitals. So they were all deployed immediately to West. That's what I mean. Those are all resources specifically. If something happened right now in Del Rio or Hondo or Castroville, those initial resources can start moving literally within an hour, probably within 10 minutes, actually.
We did have a tornado hit San Antonio. We're not in Tornado Alley.
We did. Where's Dr. Myers isn't here. It took the roof off his apartment while he was sleeping, so he woke up with no roof. There he is. Am I right?
Was it Dr. Myers?
It was.
You were in Building 13? Yeah. The tornado came and took 2 out of the 3 power turbines off of UT, and nobody got hurt. It swung around and then took out half the windows in the front of the VA, and then hit Building 13 behind Wendy's.
Where you were sleeping, right?
Were you in the same?
They removed the roof off of his apartment.
Were you the one that was in a tub? Somebody was. So no. Somebody took coverage.
That's not a visual we wanted to see.
Yeah. Not taking a bath. I gotta get rid of that image in my head now too. No, but somebody on the 3rd floor actually hid in the tub. It was one of our residents, and he watched the roof go right off the building. So we still kicked him out of residency for other reasons. That's it.
Always to end on a positive note.
Yes.
PPG.
This is a very interesting talk, especially for most of the residents, but I've never seen it addressed very much. What is the role of residents when these things happen? How they can happen? and many patients you still have the same patient and you need to start kind of having plans for them. What is the consensus? What is the instrumental regarding to all of this?
Well, it'll be the same role you currently provide with respect to just a matter of the scale of the event, right? Could be something a really busy Friday night to something that really is a disaster. That a real true disaster is not the same as routine medical care. That means you're going to stop all of your elective. You're going to stop all of your elective ORs. You're going to move patients out. They're going to go somewhere else. You're going to totally change the way you do things. And so in that situation, people adapt into roles based on what their skill set is in that specific instance. So you'll be functioning like you normally would, providing care to really doing all the work. It's probably the right response.
So even if the hospital.
The same people who do the work normally.
Especially at night, right? So to say the hospital is full, it really isn't. We heard a paper at Texas Surgical where there's a hidden hospital of empty beds just because of the way they keep the census. To comply with Medicare rules, they don't count it until midnight. And so there are beds, and we need to be able to triage our patients. That's what we do in the exercise.
There are beds if you do something differently, right? And if you have communications with other hospitals and can move patients, there are beds.
All right, thank you very much.
Thanks.
Quickly grab some coffee.